Hi, my name is Atif Darwish, professor of OPGY in Asyut University, Egypt. Today I would like to discuss with you an important practical topic of antiphospholipid syndrome, and I think most of the obstetricians and gynecologists face every now and then one or more of the cases of antiphospholipid syndrome, and we should realize that it is not uncommon disease in our clinical practice. Fortunately enough, all women are at the hypercoagulable state when they got pregnant, and this is good for females because hypercoagulability will prevent intrapartum and postpartum hemorrhage after separation of the placenta, and this occurs by a relative increase in the coagulation factors and fibrinolytic inhibitors despite relative mild decline of platelets during pregnancy. This status outweighs the natural anticoagulation including protein C, protein S, activated thrombin, 3 fibrinolytic factors. So the hypercoagulable state of pregnancy is advantageous for most of the females by preventing hemorrhage intrapartum or postpartum. But this hypercoagulability will increase the risk of thrombosis by 3 to 5 times or folds if compared to non-pregnant women. So the advantages of hypercoagulability outweigh the risk of thrombosis because hypercoagulability saves the life of millions of females. If we add the pregnancy as a status for a female, in addition to doing cesarean section, for example, surgery, in addition to immobilization due to any cause, including the surgery, in addition to these factors as increasing age of the female, all these factors will increase the risk of thrombosis more than 3 to 5 folds. So some women are at higher risk of thrombosis. We have to put in mind the risk increases with the increased age of the patient, cesarean section, immobilization, and these factors would make alarm for us to take care to avoid thrombosis formation. If we go back to the basic science, we should know that we have two types of damage of the tissues to enhance or to initiate thrombus formation: tissue damage and endothelial damage. Tissue damage is the extrinsic pathway where tissue damage leads to activation of factor 10 using or with the aid of factor 7, and factor 10 will lead to activation of prothrombin to thrombin, and thrombin will activate fibrinogen to fibrin clot. And these simplified issues are actually very complicated and sophisticated and needs a lot of time to study it well. But this is the basic knowledge of extrinsic pathway, which is tested by estimation of prothrombin time and concentration, and we have an intrinsic pathway which is initiated on endothelial damage inside the blood vessels and starts by activation of factor 12 until it reaches to factor 10, and the common cascade starts by activated factor 10 to until fibrin clot. And this coagulation cascade actually is not responsible for thrombus formation alone. It needs support with platelets to make the thrombus itself. And the testing of the intrinsic pathway is by activated partial thromboplastin time. So to form a thrombus, the cascade starts by tissue injury or endothelial injury, which is intrinsic pathway, and cascade starts until fibrin occurs. But fibrin alone is not sufficient. It needs platelets to be activated platelets, and the activated platelets with fibrin will form fibrin stabilized platelet plug that clots and occludes the bleeding site. And if this process continues, this means that the blood vessel will be occluded by the fibrin stabilized platelet plug, and the thrombus will expand all over the blood vessel. So the activation of fibrinolytic cascade starts at that point to avoid progression of this fibrin stabilized platelet plug, and fibrinolytic cascade leads to degradation products from this plug or complex to make the thrombus localized to the site of endothelial damage. And this cascade is very important. So we have coagulation cascade to make a clot by the platelets, activated platelets and fibrin, and at the same time starts fibrinolytic cascade to stop progression of this thrombus. This is very important. And one of the important issues for fibrinolytic activities is to involve protein C and S to prevent coagulation, because protein S is attached to the surface of the platelets, and we have to consider that the surface of the platelet is phospholipid membrane with some receptors of proteins on its surface. So the platelet is surrounded by phospholipid, and that's why in patients with antibodies against phospholipid, they may have thrombocytopenia, because this antibody will destroy the phospholipid membrane of the platelets in those cases. So don't forget this point. And the surface of the platelet, which is phospholipid, is attached to the protein S and activated protein C complex, and this complex will lead to inhibition of activation of factor 5 and factor 8, and this inhibition will lead to prevention of propagation of the clotting mechanism of the intrinsic and the common pathways, and this is very important. So factor 8 and factor 10 are suppressed, and activation is suppressed by protein C and S. So this is a crucial point to understand the topic of antiphospholipid syndrome. We have a coagulation pathway, we have fibrinolytic pathway at the same time, and coagulation pathway should be inhibited by fibrinolytic pathway to prevent propagation of this thrombus. So activated protein C and protein S attached to the surface of platelets, they, in addition to some phospholipids, this will prevent coagulation cascade. Some people have in their circulation have antibodies against phospholipids, whatever may be the phospholipids. I told you just now that the membrane of the platelet is phospholipid, so number one, they will have antibodies against the platelets and antibodies against these phospholipids that are important for the coagulation cascade. So by this way, if any individual has an antibodies against phospholipids, this individual will have some sort of thrombocytopenia due to destruction of the membrane of the platelets, and will have decreased phospholipids in the circulation. By this way, this individual is liable to coagulation, is liable to thrombus formation, and this is the basic concept of antiphospholipid syndrome. So antiphospholipid syndrome is a sort of thrombophilia, which is a big terminology for blood clotting disorders with increased risk of thrombus formation in the blood vessels. So it is a thrombophilia disease. We can categorize thrombophilias into inherited and acquired. Inherited, some factor deficiency like protein C, protein S deficiency, which are important for destruction and deactivation of factor 5 and factor 8. So any individual with protein C or protein S deficiency is liable to thrombus. Other factors is liable to thrombus. So this is called inherited, and actually it is a genetic alteration of functional protein in the coagulation cascade. But now we will concentrate on acquired thrombophilia, which is antiphospholipid syndrome, and actually it is only acquired thrombophilia that is associated with pregnancy complications. But we have to put in mind that many patients with antiphospholipid syndrome are actually autoimmune patients with some autoimmune diseases like systemic lupus erythematosus. And this is important because if you face a pregnant case with systemic lupus, you should put in mind that she is liable to be antiphospholipid syndrome. You should ask for the antibodies for antiphospholipid syndrome in this particular case. Don't forget, don't ignore, she's liable to complications of antiphospholipid syndrome. So the association of some autoimmune diseases with this acquired thrombophilia should be put in mind. Actually, antiphospholipid syndrome is an autoimmune disease. It can be primary, as I told you, without any genetic cause, without any deficiency, and maybe secondary to some autoimmune diseases like systemic lupus. Is it a real name or a misnomer? We don't know. Actually, some people mentioned that the antibodies will not attack the phospholipid itself. They will attack the binding protein to the phospholipids, like the binding proteins on the surface of platelets or elsewhere. So it may be a misnomer, but this does not matter so much. So the antiphospholipid syndrome, antibody syndrome, is summarized in this slide. It is an acquired immune-mediated hypercoagulable state. Acquired, not primary, immune-mediated, and it is associated with thrombus formation. So this thrombus may lead to vascular occlusion, whether arterial, venous, or vasculopathy, or recurrent spontaneous abortion, recurrent cardiovascular events, or thrombocytopenia, as I told you. So to diagnose antiphospholipid syndrome, we should put in mind that we have to classify antiphospholipid syndrome into 3 categories. This is very important to put it in your mind in your clinical practice. The vascular or thrombotic antiphospholipid syndrome is associated with venous or arterial thrombus, and often it is multiple. And obstetric antiphospholipid syndrome, which is associated with pregnancy problems, with sometimes moderate thrombocytopenia, as I told you, because of destruction of the phospholipid membrane. This is not sufficient. If we have a pregnant woman with venous or arterial thrombosis with recurrent pregnancy loss, this is not sufficient to diagnose antiphospholipid syndrome. The important issue of diagnosis of antiphospholipid syndrome is to diagnose it by laboratory investigations, including antibody estimation of these of the antiphospholipid antibodies. And these antibodies actually are responsible for the thrombus formation, are responsible for the thrombocytopenia, and responsible for fetal loss. And these antibodies are formed in some individuals, we don't know why, because it is an immune disease, and these antibodies are made by mistake for some phospholipids inside the body of some individuals. So it is, as mentioned by the American College, it is made by mistake against certain substances in the blood vessels. The commonest classification used to diagnose antiphospholipid syndrome is the Sydney revision of the antiphospholipid syndrome. It includes at least one clinical criterion and at least one laboratory criterion, And so we cannot say that this patient has antiphospholipid syndrome based on clinical presentation of recurrent abortions or thrombus during pregnancy. No, it is not good. It is not sufficient. You should realize that the antiphospholipid syndrome needs at least one clinical and one laboratory criteria. So the clinical criterion includes thrombus formation. This is thrombotic antiphospholipid syndrome, or pregnancy morbidity, which is obstetric antiphospholipid syndrome. Thrombus may be arterial, venous, or vasculopathy. Pregnancy problems, this is important to understand. If we have a patient with recurrent early pregnancy loss, she should have at least 3 first trimester abortions before 10 weeks to say that she is possible to have antiphospholipid syndrome. But if you have a patient with just one first trimester abortion, this does not raise the possibility of antiphospholipid syndrome and may not indicate asking for the laboratory investigations. So at least 3 abortions in the first trimester, but you can depend on one abortion if this pregnancy is more than 10 weeks. So if it is 10 weeks or more, you can ask or request antiphospholipid antibodies if one or more late fetal loss more than 10 weeks. So first trimester or more than 10 or less than 10, this is crucial for requesting the antibody testing. And this pregnancy or obstetric antiphospholipid syndrome is associated with recurrent early miscarriage, less than 10 weeks, late pregnancy loss, more than 10 weeks, and placental insufficiency in late pregnancy. This is very important because it may lead to placental insufficiency diseases like intratracheal restriction, fetal distress, and preeclampsia. Now, what about the laboratory criterion at least one laboratory criterion to diagnose the antiphospholipid syndrome based on Sydney revision? And this criterion should be persistent over 3 months. Single measurement is not sufficient. You should make at least 2 measurements, at least 3 months apart. And this is very important for diagnosis. And these are basics for the laboratory diagnosis, and they are put to avoid overdiagnosis, to avoid overusing the treatment. The treatment, you will see, it is tedious, expensive, risky treatment, and we should not use this treatment except on basics. And these basics include at least 2 testing and at least 3 months apart of increased level of either lupus anticoagulant, and this is plus minus, means positive or negative, or moderate to high titer of anti-cardiolipin antibody, whether IgG or IgM, or moderate or high titer of anti-beta 2 glycoprotein 1, IgG or IgM. And these are very essential to put in mind in your clinical practice. From this slide, you can put in mind that we have at least 2 types of antiphospholipid syndrome. We have thrombotic antiphospholipid syndrome, which means that this syndrome of these antibodies will lead to thrombus formation. And these thrombi may be venous thrombus, and commonly it is deep venous thrombosis, or seriously may be pulmonary embolism. If it is an arterial thrombus, this is a bad event for a woman, and this may lead to stroke or myocardial infarction. And these are risky thrombi, whether venous or arterial. Clinically, usually we notice deep venous thrombosis in those cases more commonly, but the others are more risky and more serious and sometimes life-threatening for the women. So we have venous and arterial. This is thrombotic antiphospholipid syndrome. Also, we have another type of antiphospholipid syndrome, which is called obstetric antiphospholipid syndrome, which is associated with early or late fetal loss, preterm labor, preeclampsia, placental insufficiency, eclampsia, intrauterine growth restriction, and so on. Why we classified this syndrome into these categories? Because you should put in antiphospholipid syndrome in your mind when you are dealing with any case of pregnancy complications like pregnancy losses, preterm labor. So as I told you, we have two types of antiphospholipid, obstetric and thrombotic antiphospholipid syndrome. This is crucial for the plan of management. But we should add another type, which is called asymptomatic antiphospholipid syndrome. Some patients with positive antiphospholipid syndrome antibodies, which is laboratory antiphospholipid syndrome, without any history of obstetric antiphospholipid syndrome or thrombotic antiphospholipid syndrome. This category is called asymptomatic antiphospholipid syndrome. And if we go back to Sydney revision, this is not antiphospholipid syndrome. As I told you, we should have at least one clinical criterion and at least one laboratory criterion. This patient has one or more laboratory criterion and no clinical criterion. But this class or group should be put in mind as a risky patient as well, because they have a risk factor from the studies. They may have a risk factor for development of preeclampsia later on in the pregnancy, despite no history of thrombotic or obstetric antiphospholipid syndrome. So it is recommended to prescribe low-dose aspirin for those women from 81 to 100 milligram daily during the pregnancy to avoid occurrence of obstetric or thrombotic antiphospholipid syndrome. So it's a little bit screening and prevention of these complications for this particular group with insufficient criteria for antiphospholipid syndrome. Now, and this group of asymptomatic antiphospholipid syndrome may raise the question, is it recommended to screen for all women, pregnant women, to have antiphospholipid antibody estimation in the circulation? No, it is not a routine estimation. Sometimes these antibodies are done by chance, on the patient's request. Some women heard about this disease. Some women may have sisters or friends with history of deep venous thrombosis, history of pregnancy losses, and they are afraid of having the syndrome which occurred in her sister or in her friend. So sometimes you may ask for estimation of the antibody titer in the circulation, but actually this particular patient has no history of thrombosis or pregnancy losses. So this category is important and put in new classification of the American College of Rheumatology in this year of 2020. So asymptomatic women is not a typical case of antiphospholipid syndrome. But the obstetric and thrombotic antiphospholipid, you should have at least one laboratory criterion plus in the obstetric plus prior pregnancy complications, and in the thrombotic plus prior thrombotic complication like arterial or venous thrombosis. If we go to the evidence, level 1 evidence means that at least one clinical and at least one laboratory criterion is sufficient for diagnosis of antiphospholipid syndrome. This patient has antibodies against what? Against any phospholipid containing tissue in this individual. This phospholipid is present on the surface of platelets, so we'll have destruction of the platelets and the surface, and they will lead to platelet aggregation together. Also, these antibodies are present inside the blood vessels, so they will inhibit protein C and protein S and some factors that are important for fibrinolysis, and subsequently coagulation cascade is stimulated. These antibodies will attack the endothelial cells inside the blood vessel, the wall of the blood vessel, and this will lead to increased tissue factor adhesions, molecules, and pre-inflammatory or pro-inflammatory cytokines. And importantly, for the obstetric antiphospholipid syndrome, these antibodies attack the placenta and will lead to defective placentation and decreased trophoblastic cell growth and increase apoptosis in the placenta. So these antibodies are not innocent, are not quiescent. They are they are attacking different parts of the body. They will attack the blood vessel wall. They attack the blood itself. They will attack the platelets in particular, and they will attack the placenta. This is a serious disease, and that's why it has a variety of presentations. And this is an presentation of the first and second heights of vascular affection during antiphospholipid syndrome, and this is placental affection, which is defective placentation and destruction of the trophoblast and stimulation of apoptosis by these antibodies, particularly anti-beta-2 glycoprotein antibodies, and this is essential for causing placental insufficiency with its sequelae. Now we are suspecting this case to have antiphospholipid syndrome from history, because she has a bad obstetric history of first or second or third trimester complications, as I told you, or she has a history of deep venous thrombosis or stroke or whatever. How to test for antiphospholipid syndrome? We have two categories of testing. We have an insensitive screening test, which is called activated partial thromboplastin time, and this is actually a test of the intrinsic pathway of coagulation, and usually it increases in cases with antiphospholipid syndrome. But we have more specific testing approach, which is detection of the antibodies against phospholipid or plasma protein bound to phospholipid in the semen. And the positive antiphospholipid syndrome based on laboratory diagnosis should rely on two positive testing at least 3 months apart. We should have moderate to high titer of anticardiolipin and anti-beta-2 glycoprotein or positive lupus anticoagulant. And I should say that the increased positivity increases the positivity of diagnosis, which means if you have one patient with 3 positive antibodies with anti-beta-2 glycoprotein, anticardiolipin, and lupus anticoagulant, this is sure that the patient is antiphospholipid, and this case cannot be compared to a patient with just lupus anticoagulant positive. So the increased number of positive testing increases the diagnosis of antiphospholipid syndrome. And this is a presentation of testing in the lab for anticardiolipin and lupus anticoagulant antibodies, and this is essential as added by the Sydney revision criteria. After laboratory investigation, we have a patient who was positive antiphospholipid syndrome. These testing are positive, more than 40, as the previous slide mentioned, or patient with lower titer of anticardiolipin or anti-beta-2 glycoprotein. And this patient was positive but very modest positive, not high positive. This patient still has some degree of risk that is difficult to quantify, as mentioned by the American College of Rheumatology. So if you have a result from antiphospholipid syndrome which is surely positive, more than the level, more than the estimated level from the lab, this is a positive antiphospholipid syndrome. Sometimes the patient has borderline positive. This patient is still important to follow up because she has a risk of the obstetric or thrombotic antiphospholipid, but actually we cannot quantify the risk magnitude at the moment in the year 2020. So we have to wait some research at this point. Importantly to say that anti-carbamazepine testing is not sufficient alone, despite included in the Sydney revision, because it gives high positive, false positive rates in cases with infectious diseases, tuberculosis, HIV, hepatitis C, some parvovirus B19 and other autoimmune diseases. So anti-carbamazepine positive is not sufficient alone. Antiphospholipid syndrome magnitude in the positive anti-carbamazepine positive testing is not the whole cases. So don't rely on anti-carbamazepine alone. You should ask for anti-carbamazepine, lupus anticoagulant, and anti-beta-2 glycoprotein as well. So these are the laboratory criteria for antiphospholipid syndrome. We have positive, negative, or borderline, and the borderline should be put in mind as a risky case as well. Now, what is the clinical presentation? I told you we have classic antiphospholipid syndrome, or whether thrombotic or obstetric antiphospholipid syndrome, and this is the clinical presentation. And this is called the classic antiphospholipid syndrome, 1+1, 1 clinical plus 1 laboratory. Sometimes we have a patient with laboratory antiphospholipid syndrome, which is asymptomatic carrier. I told you this patient should receive low-dose aspirin all through pregnancy because they are at risk of thrombotic or obstetric antiphospholipid syndrome. Now we have two important additional categories, which is the first one is called refractory, which is called resistant antiphospholipid syndrome, which means that you diagnose the case of antiphospholipid syndrome based on 1+1, and this patient received anticoagulation in the form of low-dose aspirin, antiplatelet in the form of low-dose aspirin, and anticoagulation in the form of heparin. But the same story occurred, and she has another case, another pregnancy loss, or another thrombosis, despite treatment of this case with anticoagulation and antiplatelet. So this case is called refractory or resistant to the defined lines of treatment of such a case. And when you face a case of resistant or refractory or recurrent antiphospholipid syndrome, despite proper treatment, you should re-evaluate the case for another cause of this occurrence, like some other autoimmune diseases, like other causes of recurrent pregnancy loss or preeclampsia and so on. You should re-evaluate, revise yourself. But if you find no other problem for this case, and you gave her antiplatelet and anticoagulation, you should add some lines of treatment, which like immunomodulation, like anti-beta lymphocytes, like some lines of treatment, despite not well proved in evidence-based medicine. But you should try another line of treatment. Some people will increase the dose of anticoagulation, which is not recommended by the American College of Rheumatology. And last and most serious group of the antiphospholipid syndrome is called catastrophic, and from its name you know that it is a catastrophic group with high mortality rate, and those patients present with recurrent multiple organ thrombosis that may lead to death of the patient in a very short time. And this case is a risky case, and sometimes very difficult to treat, with high mortality rate up to 30 to 35 or 40% of cases. So these are the four categories of clinical presentation of antiphospholipid syndrome. Now we diagnose the case of antiphospholipid syndrome based on one clinical and one laboratory criteria, and how to treat this case. The patient comes to and says, I have antiphospholipid syndrome. What is the plan of management? You should start a careful, well-monitored obstetric case care for this patient, and actually this care should start before pregnancy, whether arterial or venous. So number one and most important is to prevent pregnancy. In those cases, you should tell them that you are not allowed to get pregnant. Your life will be at risk if you get pregnant. This is number one. Number two, the other cases with positive antiphospholipid syndrome, one clinical and one laboratory, you should assure them. This is another category of patients. The first, you should alarm them, and this group, you should assure them that approximately 70 to 80% of pregnant women with antiphospholipid syndrome have a successful pregnancy outcome with the use of aspirin and heparin. So don't worry. More than 70 or 80% of cases will pass smoothly without complications, whether obstetric complications or thrombotic complications. So don't be afraid, don't be worried, or don't afraid. And you should, if you need your pregnancy to be within these 80% of cases, you should stop smoking, you should stop alcohol intake, you should stop any medications, you should stop warfarin, which is contraindicated in the first trimester until 12 weeks, and after 36 weeks of pregnancy you should switch to heparin. You should use folic acid, which is important, 40 microgram daily, and you should stop any medications that may carry a risk to the patient. And lastly, you should start low dose aspirin and heparin if you are diagnosed, and you will start these lines of treatment in the early pregnancy to avoid these complications of the antiphospholipid syndrome. This is called pre-pregnancy counseling, and it is essential for this risky disease. The objectives of antenatal care is to make close observation of the maternal thrombus status and maternal obstetric status, and you should search for thrombi. Don't wait occurrence of myocardial infarction, don't wait DVT, don't wait stroke. You should start by early detection by searching for fibrin degradation products in circulation and coagulation profile of those women frequently in this pregnancy, particularly searching for renal thrombotic microangiopathies, which is commonly seen in this syndrome. Also, you should take care to avoid occurrence of miscarriage in those cases, particularly patients with history of early or late pregnancy loss, and monitoring against occurrence of preeclampsia and fetal growth restriction. The recommendations by some big societies also is to make close education, continuous education of the patient, and monitor the maternal and fetal health, and it's better to be done by a teamwork of obstetricians, rheumatologists, hematologists with special interest in the antiphospholipid syndrome. And we should highlight the role of ultrasonography, particularly Doppler ultrasonography of the uterine arteries, and this is a predictive of some complications of the antiphospholipid syndrome. So this is the plan of management of the cases of antiphospholipid syndrome. Number one, pre-pregnancy counseling. Number two, good monitoring of the patient in a multidisciplinary approach with the obstetricians, rheumatologists, and hematologists together. Now, what is the treatment for this case? What can I prescribe for this lady? I should prescribe one or two lines of treatment for this case. One is anticoagulation for this case to avoid coagulation, because this antibody will enhance coagulation in their circulation by attacking the platelets, by attacking the blood vessel wall, the blood content, and the placenta. So anticoagulation is essential for this case. The anticoagulation may be vitamin K antagonist or heparin. And we should give the patient antiplatelet line, which is low dose aspirin. So anticoagulation and antiplatelet is the basic line of treatment. Sometimes we give combination of the anticoagulation and antiplatelet. If we start with the anticoagulation, the antiplatelet, it will be low dose aspirin. We have the low dose aspirin, many studies on its important role for prevention of eclampsia and preeclampsia, and also for antiphospholipid syndrome. It should start in the pre-pregnancy counseling, and we should stop if the patient develops some bleeding like threatened abortion, and we should stop low dose aspirin approaching the delivery or elective surgery at least 1 to 2 weeks. Some studies 9 days, but at least 1 to 2 weeks is sufficient to stop low dose aspirin before planned cesarean section or normal labor. Low dose aspirin is very important. If you go back to the intrinsic pathway and extrinsic pathway, low dose aspirin is important by prevention of platelet aggregation and by inhibits fibrin stabilized platelet block by inhibition of platelet activation. This is important. See, low dose aspirin inhibits the platelet activation. And we have to know this point. The development of prostaglandins starts from the arachidonic acid with the aid of cyclooxygenase enzyme. This leads to prostaglandin formation. And we have two pathways of prostaglandins, the vasoconstrictor prostaglandins like thromboxane and the vasodilator prostaglandins like prostacyclin. The thromboxane leads to vasoconstriction and increased platelet aggregation, and this prostaglandin is principally produced inside the platelet itself. On the other hand, the vasodilator prostacyclin leads to vasodilatation and decreased platelet aggregation, and it is produced by the vascular endothelium from the cell wall of the blood vessel. So if we give low dose aspirin, actually it leads to irreversible inhibition of cyclooxygenase enzyme, and subsequently prostaglandin formation will decrease, whether vasoconstrictor or vasodilator, all of them will decrease. So what's the value of giving aspirin? You decrease the level of prostaglandins, which are vasoconstrictors, and at the same time you decrease the vasodilator prostaglandins. So no value of adding low dose aspirin by this way. No, this is not the basic concept of giving low dose aspirin. We give low dose aspirin, okay, for prevention of prostaglandin formation, the two pathways, but we should know that the vasoconstrictor prostaglandin thromboxane is formed from the platelet, and the platelet is formed from the bone marrow, and if the platelet is inactive, so the bone marrow should form new generation of platelets, and this takes around 9 days. In these 9 days, this individual will not have a vasoconstrictor prostaglandin in the circulation, or at least low level, and the platelet aggregation will decrease because it needs some time to form new generation of the platelets. On the other hand, the prostacyclins are formed from the vascular wall of the endothelium of the blood vessel, but this endothelium of the blood vessel regenerates and forms prostacyclins more rapid than the bone marrow. So the ultimate result will be decreased prostaglandins, whether thromboxane or prostacyclin, but regeneration or formation of the vasodilator prostaglandins is much more faster than the vasoconstrictor, and the end result will be increased vasodilator prostacyclins and this outweigh the vasoconstrictor thromboxane, and this figure is very essential to understand the principle of giving low dose aspirin for those cases to avoid the thrombosis. Now in the markets usually we have 60 milligram low dose aspirin tablets, we have 75 milligram, we have 81 milligram, and we have 100 milligram. What is the best dose? What is the excellent dose? Some papers mention you give 75, some mention you give from 60 to 81, and so on. We should standardize the selection criteria for the low dose aspirin. Which dose is low? So if we give it as a prophylactic dose, particularly for patients, for example, with laboratory antiphospholipid syndrome without thrombotic or obstetric antiphospholipid syndrome, you should calculate the dose at 1 milligram per kilogram daily, which means if we have a patient who is 80 kilogram, we give 81, and so on. And if the patient is proved to be thrombotic antiphospholipid syndrome or obstetric antiphospholipid syndrome, it is a therapeutic dose. You should give it in 1 milligram per kilogram, but twice daily. So for therapeutic dose for thrombotic or obstetric, twice daily. For prophylactic ones, the important here, it is factor 9, factor 5, and factor 10, in addition to prothrombin 2. And this all factors are inhibited by warfarin, which is oral anticoagulant. So the warfarin has a slow onset of action, narrow therapeutic window, frequent INR monitoring, interacts with a number of foods and drugs, with high rate of recurrent thrombus despite its use. So it is not highly effective, and actually it is not recommended as a line of treatment of antiphospholipid syndrome. This warfarin can be given to patients on heparin for other indications than antiphospholipid syndrome, like valve replacement, and it is not recommended on randomized controlled trials for antiphospholipid syndrome, and its role actually is not currently understood in this case. Now we will concentrate on the injectable anticoagulants, which are heparin. And heparin may be unfractionated heparin, low molecular weight heparin, or heparinoids. And heparinoids are group of drugs used whenever heparin is not advised to be used, like patients with hypersensitivity, patients with heparin-induced thrombocytopenia, or patients with some renal diseases. They are advised to have some heparinoids which are not actually the target of this talk, and we will concentrate on the unfractionated heparin and low molecular weight heparin. From its name, unfractionated means heparin of big molecules, fractionated means heparin of low molecular weight. Its name is low molecular, so small sized molecules, and these are the two main types of heparin used during pregnancy. And these two types are reversed by protamine sulfate, and actually response of unfractionated to protamine sulfate is a little bit lower than the low molecular weight heparin. The common used types of low molecular weight heparin are enoxaparin and tinzaparin, and these are the commonest types used in the markets. Here's that 5,000 Daltons is still bigger than the placental barrier. The placenta usually passes molecules of 1,000 or less, so most of the drugs pass the placental barrier, except some drugs of large molecular weight, including heparin and insulin, because of the large molecular weight. So heparin does not cross the placenta. So heparin does not affect the baby directly. It affects the mother, and so will affect the baby subsequently. And this is the effect of unfractionated heparin on factor 9 and 10 and thrombin, while low molecular weight heparin affects factor 10 in the common pathway of coagulation. The unfractionated is called calheparin, and the low molecular weight, as I told you, different forms in the markets. The heparin unfractionated is coming from the beef lungs and is sinal mucosa, while the low molecular weight is chemically or enzymatically formed in the lab. The route of administration of the calheparin is intravenously or subcutaneously, while the rule of low molecular weight is only subcutaneously. The half-life is short in the calheparin, and the monitoring is needed in the calheparin by activated partial thromboplastin time and prothrombin time. The calheparin is associated with side effects including thrombocytopenia due to binding to platelet factor 4 and may lead to osteoporosis due to binding to osteoclasts. These side effects are reduced in the low molecular weight. The elimination of calheparin is by enzymatic degradation at low doses and renal at high dose, while in the low molecular weight is only by the kidneys. As I told you, protamine sulfate leads to complete neutralization and partial neutralization in the low molecular weight group. Now, what is the dose of heparin? I told you about low dose aspirin according whether prophylactic or therapeutic. The same applies for heparin. According to the American College of Chest Physicians, if we give the patient without history of thrombotic antiphospholipid syndrome, we can give her prophylactic dose, which is recommended by the American College of Rheumatology as around 40 milligrams subcutaneously daily of enoxaparin, which is given once daily for prophylaxis in a patient without a history of thrombotic antiphospholipid syndrome. But if the patient has a positive history of thrombotic antiphospholipid syndrome, we should give a therapeutic dose, which is high dose of low molecular weight, at least twice daily, 1 milligram per kilogram subcutaneously, at least twice daily, to prevent occurrence of another thrombus in those cases, particularly patients with a history of arterial thrombus, which is more serious than venous, including stroke and myocardial infarction. So the estimation of the dose depends on the history of thrombotic antiphospholipid or no thrombotic antiphospholipid. Prophylactic or therapeutic doses of heparin are recommended. These are different types of low molecular weight, may be present in different markets, and every country licensed one or more of these drugs. So in conclusion of this differentiation, because it is very important for clinical practice, in conclusion we should know that the low molecular weight is more advantageous than unfractionated heparin because it leads to less inhibition of platelet function, lower incidence of thrombocytopenia and thrombus formation, lower incidence of osteoporosis, safe for use during pregnancy, more practical for long term because of longer half-life, little or no laboratory control, and less injections. And these are advantages. But what about disadvantages of low molecular weight heparin? Of course, it has disadvantages. It is more expensive than unfractionated heparin. It needs increased dose with increased gestational age due to increased metabolism with increased pregnancy. So this adds more cost, more injections, and more inconvenience for our patients. So nothing without disadvantage. Now we gave our patient heparin throughout pregnancy, and now we are preparing this patient for delivery. When to stop heparin before delivery for fear of excessive bleeding in this delivery, whether normal or vaginal. It depends upon the type of heparin. If you are giving low molecular weight heparin, I told you it has a longer half-life. So you should stop heparin at least 12 hours before normal delivery or cesarean section. If it is prophylactic dose, which is around 40 milligram daily subcutaneously. But if you give intermediate or therapeutic dose, which is 1 milligram per kilogram subcutaneously twice daily, you should stop the administration of heparin at least 1 day before the planned delivery. So the dose is affecting the time of stoppage of heparin administration. If prophylactic dose, at least 12 hours. If therapeutic, at least 1 day before delivery. And now the patient delivered by whatever, normal or cesarean section, we can resume heparin again to avoid the occurrence of postpartum venous complications like pulmonary embolism or deep venous thrombosis. And this resumption will start 3 to 8 hours after the delivery, unless excessive bleeding due to any cause occurs. So you have to stop. You have not to resume heparin unless her hemostasis status is controlled. So stoppage at least half day if prophylactic and 1 day if therapeutic dose, and resumption after around 8 hours after delivery. Now we have another patient with unfractionated heparin with short half-life. So you can stop this unfractionated 4 to 6 hours. This is quite sufficient before cesarean section or normal labor because of short half-life. And resumption of this unfractionated heparin again after 4 to 6 hours after control of the hemostasis status of this patient. This is important. And this is anticoagulation or antiplatelet lines of treatment. I told you we have another line which is combination of anticoagulation and antiplatelet, which is commonly prescribed for patients all over the world. Combination of anticoagulation because it works on the platelet, anti-platelet occurring works on the platelet, and the anticoagulation because it works on the coagulation cascade. So we have two different mechanisms, and two different mechanisms are better than one. So they achieve higher life birth rate if compared to any single line of treatment. And this is proved by Cochrane reviews. One of them is very recent in this year. So prescription of combination of anticoagulation for the coagulation cascade and antiplatelet for the platelet function is more advantageous than prescription of any one of these lines. And this is a figure from an older study, shows that combination, which is the red column, achieves better control and better life birth if compared to unfractionated heparin or low molecular weight heparin versus aspirin, and this is clear in the Cochrane review. Okay, some doctors will add new additions to the prescription drugs, in addition to low dose aspirin and heparin. They add corticosteroids. Why corticosteroids? Because I'm afraid of recurrent first trimester loss, and it is a good line of treatment of refractory obstetric antiphospholipid syndrome. So it is advantageous, and we can give 10 milligram daily from the post-pregnant cyst until 12 weeks for cases with first trimester abortion and to maintain pregnancy. But the recent recommendations of the American College of Rheumatology published this year strongly recommend against adding prednisone to prophylactic doses of heparin or low molecular weight heparin or low dose aspirin in patients in whom standard therapy has been unsuccessful. So it is not recommended as an additional step for refractory obstetric antiphospholipid syndrome or refractory thrombotic antiphospholipid syndrome. Moreover, it carries the risk of using corticosteroid, which is a hormone with some serious complications, you know them. Others use intravenous immunoglobulins aiming at improving the immune status, because you told us that this is an immune disease. So we give immunoglobulins intravenously with many mechanisms of action, but the studies proved no significant improvement in pregnancy outcome, and of course it is a tedious line of therapy, intravenous, and it is expensive. So the studies did not prove any improvement in pregnancy outcome on giving intravenous immunoglobulins. The same was recently recommended by the American College of Rheumatology, and they recommended against its use. Also, they recommended against increasing the dose of low molecular weight heparin dose. Some doctors give prophylactic doses for patients need prophylactic anticoagulation, but the problem persists, and subsequent pregnancy the patient may have the same story. It's called refractory. So he increases the dose of heparin. This is not recommended by the American College. Increasing the dose will increase the risks of heparin, and complications of increased dose may outweigh the benefit, and no studies proved improvement on the pregnancy on increasing the dose of low molecular weight heparin. But we should search for new improvements. Some cases are refractory, and really in the practice we face many cases who fail to respond to anticoagulation and antiplatelet lines of treatment we know. So we should search for additional improvements, and one of these additional improvements include immunomodulation, which make some modulation of the immune system to prevent pregnancy complications, like anti-malarial drugs like statins, like beta lymphocyte cell inhibition or complement inhibition. The famous hydrochloroquine is reported to be safe during pregnancy without increased risk of congenital anomalies, fetal death, fetal losses, prematurity, and other obstetric complications, and this has been proved in some systematic reviews. And statins also are under investigation, particularly in patients with preeclampsia. Vitamin D also has been tested as anti-thrombotic and immunomodulator drug, which is cheap and available elsewhere. And these are the additions for the lines of treatment, but still need more randomization and more studies to confirm their role in the modern practice. Lastly, in this talk, I'd like to address an important issue which is increasing in this practice nowadays, which is antiphospholipid syndrome and assisted reproductive techniques. Any patient subjected to assisted reproductive techniques is subjected to stimulation of the ovaries, and ovarian hyperstimulation is associated with increased estrogen level, and increased estrogen level will lead to increased risk of thrombosis, whether venous or arterial, with increased risk of organ or life-threatening thrombus, and the risk of thrombus may outweigh the risk of bleeding if we give the patient anticoagulation. So we should put in mind that those patients have high level of estrogen in their circulation. Moreover, there is a flare in the systemic lupus patients when they are subjected to ovarian hyperstimulation, and this also increases estrogen level. So in induction protocol, it's recommended to give the least dose that leads to increased estrogen, but not in a very high level, and this can be monitored by estradiol estimation on day 3, day 8, and time of HCG administration. Better to use induction protocols that lead to lower peak of serum estrogen to minimize the risk of thrombus in those cases with antiphospholipid syndrome, particularly thrombotic antiphospholipid. So in cases with asymptomatic or obstetric antiphospholipid syndrome, we give them prophylactic dose of anticoagulation. And as I told you, the classification of asymptomatic, obstetric, and thrombotic is very important for the management plan. Now, one of the importance of this classification is to categorize patients into asymptomatic and obstetric as one group. In those cases, we give them prophylactic anticoagulation, which is usually 40 milligrams subcutaneously daily. And in the thrombotic antiphospholipid syndrome, the most risky group with high level of estrogen due to superinduction, so these patients should receive a therapeutic anticoagulation, which is 1 milligram per kilogram twice daily subcutaneously. And we should know that anticoagulation is only prescribed for those patients. We don't have to prescribe antiplatelet until egg retrieval, because the antiplatelet has a prolonged effect up to 2 weeks. So if you give antiplatelet with induction of ovulation, this is risky. This is very serious and may lead to excessive bleeding during egg retrieval. And starting anticoagulation at the beginning of ovarian stimulation, because in this beginning of the cycle there is increased level of estradiol with increased risk of thrombus formation, and you should stop prescribing anticoagulation, which is heparin, at the time of HCG administration, which is around 36 hours prior to oocyte retrieval, to minimize the risk of bleeding on egg retrieval from the punctures of the ovaries and to avoid internal hemorrhage. And you can resume the heparin again after the procedure, after confirmation that the patient has no bleeding, after doing ultrasonography and no hemorrhage from the ovaries. You can resume the anticoagulation again. So it is very important to classify the patient into two groups: asymptomatic and obstetric antiphospholipid as one group and thrombotic as another group. It depends on this classification, the dose is selected, but in both groups you should start at the beginning of ovarian stimulation and stop at the time of HCG administration and resumed immediately after egg retrieval. Resumption of anticoagulation after egg retrieval continues for the whole period after egg retrieval in cases of obstetric or thrombotic antiphospholipid syndrome until delivery if pregnancy occurred. But for cases with asymptomatic antiphospholipid syndrome, we should continue anticoagulation with heparin until the level of estrogen returns to normal, near physiologic level after the hyperstimulation of the ovaries. After that, the patient should be put on antiplatelet therapy or prophylaxis, which is low-dose aspirin daily for fear of preeclampsia and late pregnancy. What about low-dose aspirin? It is not commonly used prior to oocyte retrieval. You should start it after oocyte retrieval if indicated, given concern that its prolonged action up to 2 weeks may increase bleeding risk at the time of egg retrieval. So the difference between low-dose aspirin and heparin is that low-dose aspirin should start after retrieval, but heparin should start at the time of ovulation induction. Because the half-life of heparin is maximally 12 hours, so you should start it in the beginning of the cycle stimulation and stop at least at the time of HCG administration. While low-dose aspirin has a prolonged duration of action up to 2 weeks, so you should stop, you should not prescribe it in the first half of ovulation stimulation, and you should start it after egg retrieval until pregnancy is completed. Is it allowed for vaginal delivery for those cases? The recent recommendations that those cases are advised to have vaginal delivery better than cesarean section because of lower risk of postpartum thrombosis, and it's better for the baby. Postpartum care, they are allowed to nurse their babies, and both vitamin K antagonists and heparin are compatible with breastfeeding. For obstetric antiphospholipid syndrome, we give prophylactic dose of anticoagulation for 6 to 12 weeks postpartum. For thrombotic antiphospholipid, we should treat them. It is not prophylactic. We should treat them, as I told you, 1 milligram twice daily subcutaneously, 12 hours apart, with low dose aspirin and therapeutic dose of heparin throughout pregnancy and postpartum period. What about contraception? The best contraception, the preferred contraception for this group of patients with antiphospholipid syndrome based on the evidence-based medicine is intrauterine contraceptive device, whether copper or medicated by norgestrel. And if they are not suitable for the intrauterine contraceptive device, you can prescribe many pills because they have low dose of progesterone but less effective than intrauterine device. It's better to avoid prescription of COCs for this group of patients according to the American College of Rheumatology recommendations. And COCs have increased risk of thrombus formation, of course, so they are not allowed for patients with antiphospholipid syndrome. Transdermal patches, vaginal rings are not allowed. So any drug containing estrogen is not recommended for those cases because they increase risk of thrombus formation. They added depo-medroxyprogesterone acetate injection, which is used for a 3-month contraception injectable, despite being progesterone, because some limited data on this drug has proved to be having a higher venous thromboembolism risk than other progestogen-only contraceptives. So it is not allowed to prescribe depo-medroxyprogesterone acetate for patients with antiphospholipid syndrome in addition to any compound containing estrogen for this group of patients. And in conclusion, I would say that antiphospholipid syndrome is a common problem that should be put in mind in cases of recurrent pregnancy loss, preterm labor, with particularly those with preeclampsia or placental insufficiency, and this is for obstetric antiphospholipid syndrome. For thrombotic, of course, for patients with venous or arterial thrombotic manifestations. Future of anti-thrombotic medication to enhance the effect of anticoagulation and antiplatelet lines of treatment is promising and should be encouraged by many studies worldwide, particularly multicentric large sample size studies, to settle the rule in the clinical practice. Thank you very much for your attendance of this lecture. If you liked it, please press on like icon, and if you need more lectures, please press on the subscribe icon and notification icon as well. And if you need any questions, if you need to interact with me regarding this lecture or other lectures, please contact me on the email address atif_darush@yahoo.com, and see you again. Bye bye.